On this episode of the Ask Mike Reinold Show, we talk about knee extension strengthening exercises after ACL reconstruction and really about that whole 90-40 concept.
The Ask Mike Reinold Show. Helping people feel better, move better, and perform better.
Before we get to the podcast, I wanted to make sure you knew about my free online course on the Introduction to Performance Therapy and Training. If you want to learn how to get started optimizing and enhancing performance, this is the course for you. Head to mikereinold.com/performance to sign up today. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We're up at Champion PT and Performance up in Boston, Massachusetts. Mike Scudo, Dan Pope, Dave Tilley, Lenny Macrino, Lisa Russell here answering the asks that you have for questions for us. So Len, what do we have for students today?
We have Nick Framagioli from Duke University. Just kidding. Framagiel from Duke University. We have Fernando Espinosa from University of Wisconsin-Madison. And we have Joe Gouette from Virginia Commonwealth University in the Commonwealth of Virginia University.
Who's up today? Big Joe?
Yeah.
Big Joe. When are you done, by the way? You almost done?
End of March.
Oh.
4 weeks.
Jeepers.
Still weeks left.
Wow.
Considering it's December.
Got a whole month. Yeah, all right. Awesome. All right, Joe, what do we got for a question today?
All right, we got Matt F. from Down by the River. When using single leg extensions after ACL reconstruction, do you have patients perform them in a shortened range from 90 to 40 degrees? Or do them in whatever range is pain-free? If you use a shortened range, when will you open that range up?
I mean, one of the best questions we've had in weeks right there. And how well articulated by Joe right there. I think that was like dramatic. I felt some suspense with that. That was
really good.
That was fantastic. And I will say, I feel like every now and then we're getting like these, what are they, pseudonyms? Is that what it is? Pseudonym?
Yeah.
Down so by is that Matt Foley?
Foxborough.
In his van down by the down by the river.
I get your Tommy Boy reference. Oh, that's not Tommy
no,
Boy.
it's
That's
SNL.
Chris Farley.
SNL. Close. But you know what my guess is? Is it's just all the same person, and they just don't want to just keep asking questions under their name. So I like it. Good questions though. So all right, 90-40, right? So after ACL reconstruction, knee extension from 90 to 40 degrees. Very commonly recommended range of motion because from 40 to 0, your leg will blow up if you do that at that point at any point. Len, why don't you tell us a little bit about maybe the origin of that?
Historically, yes. Historically, it's been limited after an ACL. There is thought that the tibia does translate anteriorly a little bit more in the last degrees of range of motion from 40 to 0. So if we're trying to limit anterior translation of the tibia on the femur after a reconstruction, after an ACL reconstruction, then we want to block or stop the patient from going those last 30 or 40 degrees. With that, I mean, I've tried. I even spoke to Kevin Wilk, and he still does it, and I still respect the precautions too. I just pulled back on my precautions with that. So I do it. I just do it a little earlier than I used to. I don't wait the 12 weeks.
Do what?
You do full range of motion. Yeah, full active.
So 90-40 historically, there is a little bit about, does obviously just biomechanically that the pull of the quadriceps pulls the tibia anteriorly, right, which will then put a little bit more strain on there. Well, let's talk about strain. You talked about motion though, but what's the strain?
The strain that I've seen in some of the studies that are out there, Escamilla has a nice review. I think that was JOSPT 2012. That he basically captured all the literature at that time, so it's 8 years ago, and a lot of the studies are from Dr. Benyon. Put a lot of strain gauge studies out back in the day, back in the 90s and early 2000s. In vivo, correct, and showed 3% strain to maybe 4.5% strain for most of the open chain stuff. So. And that was using, I think, roughly 10 to 20 pounds of force. So an ankle weight, right, that we would do 3, 4, 6 weeks out of an ACL surgery typically. So with that, because I've seen that, I tend to do it sooner than the 12 weeks because I don't think magically at 12 weeks things are any more somewhat healed than at 6 weeks. We know the graft takes years to mature, right? 1 to 2 years if it's an autograft. So I do it sooner because of the Benyon studies and that Escamilla review paper that I highly recommend you guys read. And I haven't seen the increased translation. Not that I'm doing a KT test on people. I haven't seen the issues that we think could potentially happen.
Yeah, that's a good point.
And that, again, I'm more so, I see a lot of patella tendon grafts. I will go a little slower in general with a hamstring graft because of the soft tissue fixation. But with a patella tendon graft where it's bone and bone, I'm definitely more aggressive in how I treat those people post-op.
So I think biomechanically, a little bit, again, where this started was, the Ben and Fleming studies, they obviously had a lot of strain gauge type research that showed some strain with comparatively open kinetic chain versus closed kinetic chain. That's where this all started. Yeah. Open chain versus closed chain. And what they showed was closed chain just didn't have that anterior stress, that strain, I should say. It didn't have it. And open chain at terminal knee extension did. So they said, let's stop. Then, we started to learn a little bit more, right? So one thing we did note as they published subsequent studies is that when you increase the amount of weight on your knee extension, the strain goes up linearly as well. So that's an interesting kind of component. Maybe you can do full range of motion, but with less weight at the beginning. That's an important part. But then what really started happening is we started kind of opening up the window a little bit and kind of saying, what other activities should we look at? And then all of a sudden things like walking and going up and down the stairs and riding a bike and some of the basic ADLs that they do also had some small amounts of anterior strain. And I think that's kind of where people started saying, like, well, wait a minute, if just some of the ADLs that we do have a little bit of a strain, then it is the strain that is observed from 40 to 0 degrees, is it clinically relevant? And I think that's kind of the question that came up. So, I don't know. I don't know I don't know if we know the answer. I do know that a lot of well-respected people probably still follow those guidelines a little bit. And I don't know. Are we struggling? Should we change these things? I think the answer is you probably could go all the way to extension, but you certainly probably don't want to do that with a ton of weight. Yeah. And you got to be careful how you advise people nowadays, especially on social media and 30 seconds at a time, right? That somebody might misinterpret your statement to say that you can do anything all the way up there. I think that's a little bit different. So. Let me ask you a question, and maybe we'll kind of go back to the strength science of this. But why would we want to go all the way to 0? What's the benefit? What do you guys think? Anything strength-wise? What is it that does that we can't replicate with another exercise?
Oh, I will say, just in straight knee extensions, great for the quad. I don't know that you couldn't get the same thing maybe with straight leg raise or something along those lines, but it is obviously a very good isolation exercise. I think the trouble with closed chain exercises, people are so good at compensating, you might be able to compensate around it. So I can see why the knee extension might be good in someone who's just not very good at isolating their quad.
Yeah, I hate to say it, but I don't think you're going to find a better way to increase the EMG of your quadricep with something other than knee extension, especially at terminal end range.
But keep in mind, the first few weeks after surgery, I don't think you're going to make or break the rehab by doing a 90-40. It's not like if you do 90-40s only for the first month or 6 weeks, that their quad is never going to come back. Like I think we're over-exaggerating. So my position that I usually go is I wait a month at least, and then I'll start having to do active or some resisted full knee extensions. But again, if you look at some of those Benyon studies in the strain gauge, some of the curves, the strain on the ACL in full, doing open chain, active range of motion, or even weighted, is very similar to doing a closed chain mini squat. So are we having people do mini squats? Yes, and the strain is pretty close, 3 to 4%. In a closed chain position too. So we still have people do mini squats. If you look at a study that came out, I forget what it was, a few years ago, it was an MRI study looking at the strain on the ACL. They showed just walking was a 13% strain on the ACL. So it begs the question, what percentage strain are we tolerating, and do we want to put on the graft that we know is trying to mature? It needs strain on it, right? I know for the collagen to mature. So what's the percentage strain to tear the graft? I think the research is still mixed, right? If we're doing a 3 or 4% strain in general with most of our exercises, is that 25% of the strain, the total strain to tear the graft? We think the graft tears at about 15 to 20% strain on it, or the ACL tears at about 15 to 20%. So, but again, that research is still.
So we're quite sub-threshold on that. So
very much so.
I think here's the thing right now is I don't think the debate of whether or not to do full knee extension week 2 with a 1 pound ankle weight, I just don't think it's this important.
Right.
So I don't think this or this exercise is that important. So here's kind of how I kind of envision it right now. I think most importantly is make sure you're getting your passive knee extension, right? That's kind of number one. Then make sure that you can contract the quad with your knee fully extended. So like in a quad set, a straight leg raise, like Dan kind of said, that's the function we want out of quadriceps contraction at full extension. As long as you have that, I'm pretty happy with that. I'd say let's probably still start at 90 to 40 and gradually add some linear load to that, because we know at least it won't put that much strain on the graft. The things they're going to do around the house and in their daily lives is going to strain the graft a little bit. I don't think we need to pick an exercise that's also going to strain it at this point. But then once you get down the road a little bit, you start opening the window. Like Lenny said, he waits about a month. Maybe he's doing it with full range of motion. Maybe you're slowly loading it. That's fine. But then I think the real question comes down to is when do you let them get after it in a knee extension machine down the road? And that's probably looking at, like, I don't even know, is it 3 months? You kind of mentioned 12 weeks.
Yeah.
You know, I don't
That's
even.
the accepted.
I think that's when you start, but I don't even think you go crazy. It's almost like 4 months before you start getting real aggressive on that. So yeah, I think the science is changing our opinion a little bit here. I think it's changing our mind, and I think we could probably do a little bit more, but I'm just not sure it's worth it. I'm not sure if we have to. I'm not sure if we're struggling with anything that this is going to solve. Right? So I don't know. I just think I would probably, it's not the end of the world if you do it, but I also don't think like by you doing it, it's doing that much benefit, right?
No, I think we struggle with the last 3 months of the rehab. I think we got to focus on that more so than the first 3 months of the rehab. Get the motion back, like you said, especially extension, and then really be able to focus on those last 3 months of rehab when the strength gains are going to be huge and required, and the functional aspect of returning.
If you're 4 weeks out, though, I would much rather you go 90-40 with a lot of weight, if you can do it, right, than to go all the way up with little weight. If that makes sense, I'd rather you go 90-40 with more weight, and then we'll get our closed chain going on there. So yeah, I mean, it's a little bit about the history of that, a little bit of like where it came from, and I don't know if we know the answers right away, but I definitely think there's some workarounds that will get the strength back, that will still make sure that they have terminal knee extension, right, but not put that little bit of strain just in case. Who knows, maybe we're wrong, right? These old studies, like in vivo, trust me, they didn't have a huge N, right? They literally put strain gauges in healthy people in their ACL while they were doing exercises. Think about that for a second. Those are like med students, right? Pretty funny, right? Imagine that if you got a freaking needle in your knee and you have to do an exercise, right? So like, it's interesting kind of study. So good question, because I think that's like one of those like, is that an outdated kind of concept? It may be a little bit, but probably not enough that should be like a big focus of us. So, if you want to go up a little bit, I think you probably could, but I think you just got to be careful loading it in that position. That makes sense? Is that a good answer, maybe? Awesome. Great question. Appreciate it so much. Head to MikeReinold.com, click on that podcast link, and you can ask us more questions like that. Anything you guys want to talk about, hopefully we can get them on a future episode. Thank you so much.